so much for joining in on KASS TV. It's always a pleasure to have you join us. We appreciate you. My name is Kiprono, and tonight I'm being joined virtually by Dr. Kiprono Mutai, who isn't a new face, but as you are kicking in the new year of 2026, and especially today as we are getting to the week where January is ending, we thought it's best to start or to kick off this program with a conversation about pregnant women, and especially conditions that might impact them, right? So what are some of the issues that affects pregnant women that could lead to death of the mother or the child, right? So Dr. Mutai is here tonight to discuss an issue called preeclampsia, and he's also going to mention something called eclampsia. What is it? Is it something that is preventable? Is it something that once it's detected, is it irreversible, or is it something that doctors can do something about it and save the life of a pregnant woman and their child, right? You've probably had issues to do with hypertensive, blood pressure, and conditions like that when it comes to a pregnant woman, right? So if this is something that you've probably heard about it before, or it's something that you're hearing it for the first time, then you're in the right place, because Dr. is here to explain it further to us. And let us know how we can handle this issue when and if we detect it early or not, right? So without much ado, please help me in welcoming Dr. Kiprono Mutai in the studio. Daktari, karibu sana.
My name is Dr. Kiprono Mutai. I'm a medical officer currently working at Gilgil Sub-County Hospital. I've been working as a medical officer for the last 6 years. So I do attend to women and also other patients, medical patients. But when we talk about hypertension in pregnancy, this is a common thing that we see on a daily basis. In Kenya currently, we are speaking of maternal mortality standing at around 355 women per 100,000 live births. And the commonest causes, the first one is, of course, postpartum hemorrhage, that is bleeding after delivery. And blood pressure also comes in at third, but as recently we are seeing many women presenting with hypertension in pregnancy. It's almost number 2 currently as a cause of mortality. So this is a common thing that we need to talk about, and people should understand what it is, hypertension in pregnancy, because someone will present to you and tell you that I've never had hypertension before. Why is this happening? And this is particularly in pregnancy. So when we talk about hypertension in pregnancy, there are some figures that we need to understand. We have what we call the systolic blood pressure and the diastolic. I know everyone who has gone to the hospital and has taken blood pressure. There are 2 figures. So the first one is a systolic, number ya juu, and then kuna number ya chini. So these figures, we need to understand that when someone has hypertension in pregnancy, it can happen that you didn't have hypertension before conception, and then once you conceived, you start developing hypertension. Some will have hypertension superimposed. They had hypertension before conception, and then now in pregnancy also we find the same. So these figures that we are talking about, systolic and diastolic blood pressure, I know people who've had it, they will understand, because the normal blood pressure, it's usually a range, but we say 120/80. So when it starts becoming a challenge in pregnancy is when you are having blood pressure of more than 140 over more than 90. So a blood pressure of more than 140 or more than 90 diastolic. That is when now it becomes a problem, and it will present with a number of symptoms. So what we normally call preeclampsia is it affects different organs. It can affect the kidney, it can affect the liver. So it's a multi-systemic disease. And usually there is no particular cause. Hautasema kwamba this thing is causing hypertension in pregnancy, but there are risk factors which we will talk about. Now there's something else we call eclampsia. When this pre-eclampsia, when you add convulsion, if a mother starts convulsing and they had preeclampsia, that now becomes eclampsia, and it's a medical emergency. That now becomes an emergency. So for preeclampsia, you are having just blood pressure greater than 140 or greater than 90. Some women will have protein in urine. That's why we do what we call urinalysis. Tunawatuma wapime mkojo. Some will have proteins in urine. Some will not have, but still they have preeclampsia. So it's not a thing we rely on to say that because you don't have proteins in urine, you don't have preeclampsia. It's just one of the things we use. So the first thing is blood pressure. We want to check this blood pressure. How is it? Is it greater than 140? Is it greater than 90? And this is taken at least on 2 occasions, 4 hours apart. Because mtu akikuja ameshtuka, inapimwa and then inakuwa juu, it might not actually reveal the actual thing. So it has to be taken at least on 2 occasions, at least 4 hours apart for us to establish. So if one has preeclampsia, they can present with a number of things. I know during pregnancy, we educate women on some of the danger signs during pregnancy. And some of them are related to preeclampsia, some are not. And there is a booklet here, mother-child booklet, that has some of them warning signs during pregnancy. I know each mother, I don't know if some do read this book, but there are a number of things that will help them understand some of the warning signs. When we look at it, one is severe headaches, and this can also be associated with preeclampsia because number one, if you have preeclampsia, you can have headaches which cannot be relieved by painkillers. They take paracetamol, lakini bado wanasema wanaumwa na kichwa kabisa. So that could be a warning sign that you are having preeclampsia. Some will present with swelling. It could be swelling on the face or the hands. I know it's common for women during pregnancy to have swollen feet, but we don't rely on that alone. If you have puffy face, swollen hands, then it could be pointing towards preeclampsia. Some of the other danger signs during pregnancy might not be related to preeclampsia, but there is also one, convulsions or fits. If a woman starts convulsing during pregnancy, this is a danger sign and we take it seriously because this is now eclampsia. That's why when they present to us, delivery should be very imminent. Within the next 12 hours, this woman should have delivered. It is an emergency. So it's either delivery by cesarean section, which is the easiest and the fastest, of course, because you are having eclampsia. It's a severe thing. Now, there are a number of things that I would like us to look at, what we call the risk factors, because we've mentioned that preeclampsia doesn't have causes. It has what we call risk factors. There are theories anyway around it that the major thing is the placenta. So as the placenta embeds, there are things which happen around that causes one to have hypertension in pregnancy. That's why the definitive treatment usually is delivery, because once you've delivered, you've removed the placenta. Even though it can persist after delivery, that's why we do follow up these women even up to 3 to 6 months. So when we put them on medications, we continue following them up because they can even develop eclampsia after delivery. So it's something that we do continue following them up. So for the risk factors, there are many of them. One is extremes of ages. If one is less than 20 years or more than 35 years, 40 years, that is now when we say one has a risk factor for preeclampsia. It could also be nulliparity, or the first time a woman is getting pregnant. Because now this is new. The first time a woman is getting pregnant, they can be exposed or be at risk of getting preeclampsia. If there's family history of preeclampsia, mama alikuwa na shida ya pressure, it's likely kwamba msichana wake atakuwa na shida ya pressure. So if there is family history of preeclampsia, there is higher chances of getting the same. When we talk about preeclampsia, we should understand that we are talking about hypertension in pregnancy. For other hypertension, we don't mention it as preeclampsia. Another thing is previous history of preeclampsia. So mtu amekuwa na mimba akakuwa na shida ya pressure. Subsequent pregnancies anaweza pia kupata shida ya pressure. That's why we take history, tunakuuliza umewahi kuwa na shida ya pressure in the past pregnancies? Aha, anasema amekuwa nayo. That will tell you they are likely to also get preeclampsia. If also black race, we can't change, we are all black, there are higher chances of getting preeclampsia with our race. So it's a constant thing. Also, interestingly, change in male partner. Hatuwaulizi directly, but if one changes male partner, usually what happens is that it treats that as a first pregnancy. So hata kama umekuwa na watoto wawili umebadilisha male partner, that one will be, the system will treat it as this is a first pregnancy again. So change in male partner is also a known risk factor. If someone also has conditions like diabetes, if they have obesity, if they have kidney disease, all these are risk factors for preeclampsia. And even chronic hypertension. They were having hypertension before conception. And it's very important because for people who have chronic hypertension before conception, they need to be changed or medications they are using, because there are some medications which are contraindicated in pregnancy. That's why we usually, nowadays we encourage people to attend preconception clinics. So if someone is planning to conceive, anakuja anatuambia daktari, mimi napanga kupata mtoto. That is where we begin, because we can even start giving them supplements like iron and folic acid. That is when we start changing. If they were they had chronic hypertension, we change their medications so that we give them those which are not contraindicated in pregnancy. We can be able also to screen for other things like diabetes and advise accordingly. So it's very important if one has preconception care. This is a journey, remember. So we have preconception. Once they conceive, they start antenatal visits. And this one, we encourage them to have at least 8 visits. I know initially we used to talk about 4 antenatal clinics, but we want to have them attending at least 8 visits. That's why we want to have the first antenatal visit coming early. The first time they just conceive or they understand they are pregnant, we want to encourage them to come to the clinic. That is when we do a number of things we call antenatal profile. And among us, the things we do is taking blood pressure, which is important, amongst other things that we take. So for every visit they come, blood pressure has to be taken. So it's very important. It's something that we are aware of. And a woman should also understand when they are coming, they should ask, pressure yangu imekuwa aje leo? Kama ni mtu ako na shida ya sukari pia anauliza, because these are the things that causes mortality. We've seen women losing their lives because of the same. Multiple pregnancy also is a risk factor. Remember, multiple pregnancy you're having now, about 2 placentas. And remember, we mentioned that the issue here is the placenta. So multiple pregnancies will also cause the same, and many others like chromosomal abnormalities. So for any woman who comes to us early and they are having risk factors, which we've mentioned, usually we want to prevent. So there are things that we give them. For some, we give them calcium and vitamin D. I also forgot to mention that vitamin D deficiency can also, it's a risk factor. So we want to give them calcium, we give them vitamin D, and for some, we give them aspirin, junior aspirin. It will help preventing them from getting preeclampsia. But nonetheless, some will still get a preeclampsia, and that's why we do close follow-up, and we want also to treat them if they develop preeclampsia in the process of follow-up. So there are many things about hypertension in pregnancy, and there is a way we usually classify, because if you have, someone can have preeclampsia with or without severe features. Some of the severe features that we mention is when they present to us, we want to ask them, are you having severe headaches? Anasema anaumwa na kichwa sana, anameza paracetamol, it's not even improving, there is nothing that can relieve that headache. then it tells you this is it is one of the severe features. Some will also tell you that they are having blurry vision. So anakuja anakuambia na sioni vizuri, ama wanaona some things hanging in the air. We call them scotomas. So they can be having blurry vision, or some things wanaangalia tu, some things hanging in the air. We know that this is a feature, a severe feature. Some will present with what we mentioned as puffiness of the face. Uso inafura, mikono inafura. They could be having a chest pain. Wengine watakuwa na difficulty in breathing because of the process ya preeclampsia. Fluid will build up in the lungs, so wanaweza kuwa na difficulty in breathing. Wanaweza kuwa na pain huku kama ya heartburn, epigastric pain. And some will even have vomiting because of the same. Wengine watakuwa na reduced urine output, like in 24 hours anakuambia tu ana susu kidogo, anaenda haja, the amount is less than 500 mils, less than half a liter in 24 hours. That is showing you that the kidney is having a problem, and it's one of the severe features. So there are many things that will point you that this is a severe feature of preeclampsia. So those are the things that we look at. But if a woman tells you that amekuwa na convulsion, a fit, a seizure, then you know that is an emergency. It's more than severe, it's an emergency, and you need to deliver that woman as soon as possible. So basically, there are a number of things that we do when they present to us. We will want to check the urine. We want to check the kidneys. How are they functioning? We want to check the liver, because it affects all these organs. It's a multi-systemic disease. And also, we need to understand that preeclampsia affects not only the woman, but also the fetus, or the newborn, the child to be born. We call it fetus. So for the woman, it can damage the kidneys. It can cause kidney failure. It can damage the liver. It can cause bleeding into the brain. You can have a stroke because of the same. It can even cause mortality. You can lose your life. And for the newborn, it can restrict their growth while they are still in the utero. So you can have growth restriction. They can also lead to stillbirth because of the same. And it can also cause the placenta to separate early. So placental abruption, the placenta separates early, the woman starts bleeding, they can lose their life. So you can lose both the mother and the baby because of the same. I remember a time I was working in some facility, and a mother presented to us. She had been convulsing at night. I think ikakuwa mingi, akaamua kuza hospitali, and she was expectant. So already that is telling you that was eclampsia. And because of that, it's unfortunate that we lost her. We rushed to theater. We did what we call perimortem cesarean section, because we've lost the mother. The baby is still alive. We sectioned her quickly, removed the baby, resuscitated, but the baby also didn't make. So you can see what hypertension in pregnancy does. You can lose the mother, you can lose the baby. Because I'm pretty sure if they had presented to us early enough, we would have detected this and probably saved both the mother and the baby, because the reason why we do these close follow-ups is we want to catch hypertension in pregnancy early and prevent it. We don't want it to get into the place of eclampsia. So when we catch it early, we treat it, we manage, and then we now plan for delivery. Because one of the things as we are managing this is we are looking at the delivery at the earliest point. Sometimes if you have preeclampsia with severe features, we aim at delivery even at 34 weeks gestation. So they don't usually get to term of 40 weeks. So depending, it's a case-by-case basis. So when a woman presents to us early, we want to optimize our outcomes for both the mother and the baby. That's why we would even deliver them early. So So these close follow-ups and visits will really help us to reduce the mortalities and optimize the outcomes. For those who don't have severe features, we target 37 weeks gestation. But at any point when you develop eclampsia, delivery should be within 12 hours, you've delivered. So it should be imminent. So basically, that is it about preeclampsia, and there are many cases. People present to us on a daily basis. Mtu tu anakuja, unashangaa like, na umekuwa nyumbani umekaa tu all along, anasema oh, sijui hospitali ni mbali. There are many excuses that people give, transport. So there are many challenges. First is even identifying, recognizing these danger signs. Someone is convulsing and they are thinking it's something else, and you're pregnant. So people should be wary of these danger signs. That's why when they come to clinic early, we educate them to understand. If you have any of these danger signs during pregnancy, please present yourself to the nearest facility for you to be assisted. So it's very important for them to understand. Are you having any of the danger signs during pregnancy? Are you on follow-up for hypertension in pregnancy? Which are the things that you need to look out for? So it's very important for them to understand this, and we insist that people should have preconception care. That's why currently the conversation is around formation of preconception clinics. I know it's not common for someone anaenda clinic anasema mimi napanga kupata mtoto, because I think people take it as it's a personal thing. Sasa mimi kupata mtoto ni shida yako. It's our problem, it's our concern, because we want to optimize the outcomes. Tunataka mtoto na wewe uishi vizuri, and there are some things that will pick up early. There is things we can advise. Mtu anaweza anza kumeza iron and folic acid even up to 3 months before conceiving. So it's very important for you to be followed up to jua, are you having any of the risk factors we've mentioned for preeclampsia, for example? And if you do, we want to start giving you the preventive medications as early as 12 weeks. And this one will continue up to around 36 weeks or delivery, depending on, it's a case-by-case basis. Probably in future we can still have the same, and hopefully we can find a patient who has gone through the same, so that we can also hear from them what their experience was and what they have for other women who are planning to conceive or they are having the same. Because I'm pretty sure we have many women currently who are battling the same. They are having hypertension in pregnancy, and at some point we'll need support. Because what happens, we need to understand that the management of the same, sometimes it's costly. Some of the medications that is used for treating and the ones that we encourage and are safe are quite costly, because you can find something like labetalol, a tablet going for 60 or 70 shillings, and they have to take probably 2 tablets per day. So look at someone spending 150 or 200 shillings per day for medications, and they are taking it for quite some time. So it can be costly. And some facilities, some of the things we use, because we mentioned that when you're having preeclampsia, we want to prevent it from progressing to eclampsia. What we use is something we call magnesium sulfate. And you might find it missing in some of the facilities, which is unfortunate, because it's a life-saving drug. If someone has preeclampsia, they have to get magnesium sulfate, also preventing progression to eclampsia. So the management can be costly. We do the lab works, and sometimes you hear, I don't know, SHA is not working and what have you. So they have to pay out of pocket. So it can be quite costly.
Well, as you've heard from Daktari, high blood pressure in pregnancy does not have to end in tragedy. The difference between life and loss is often early recognition, as Daktari has said, regular antenatal care, and knowing when to seek help. If you or someone close to you is pregnant, ask about your blood pressure at every clinic visit, understand the warning signs, and never ever ignore persistent headaches, swelling, or vision challenges. Daktari has mentioned about the issues of blood, right? So I've been speaking to Dr. Kiprono Mutai on this issue of a hypertensive disorder in pregnancy, and is actually called it preeclampsia. And of course, once it goes to the very critical stage. It's what we call eclampsia. So that is it from us tonight. This has been Tililinda with me, Chemtai Kirui. It's really been a pleasure having this conversation, getting to learn and understand some of the conditions that we need to handle early in advance. We need to hear from you. If you have a story, you're a patient, you're sick, you're a doctor, and you feel like this a conversation that we need to have, probably it's a condition you've been battling and you want to share so that someone else can benefit from it, or you're a doctor and you feel like you want to join in on this program so that you can share some of the ideas and conditions that you feel like our audiences need to understand, this is the home for you. Remember, KASS TV and KASS Media Group at large is here to educate and inform our people at home. So you can join in every time on Monday. Just write an email to us at kassconversation@gmail.com. You can see it on the screen there, kassconversation@gmail.com. Write an email to us. We read the story, we read the ideas that you have, and we'll get back to you if and when we feel like whatever you've shared with us needs to be heard by everyone else who's watching this program. So that's it for us tonight. Thank you so much for staying tuned. I'm hoping to see you next time right here on KASS TV. Continue watching the rest of our program. Amu Kimnatet Night.